University of Oran, Algeria, and currently works at Ibn al-Haytham Center of Specialty Contact Lenses. He is an associate professor of optometry and contact lenses at the University of Oran, a member of the British Contact Lens Association and Association of Research in Vision and Ophthalmology. Dr. Mohamed is an ambassador of the International Association of Contact Lens Educators in North Africa, an author of several publications in peer-reviewed journals, and a speaker in multiple international conferences. Currently a research associate at the Contact Lens Clinic at Waterloo University in Canada and Universidad Complutense de Madrid in Spain. He defended his PhD on orthokeratology and myopia control at University of Montreal, Canada, and a winner of several national and international awards and grants. Dr. Mohamed, welcome again.
Thank you, Ryan, for this introduction. I would like to thank the Vision Care Association for the invitation.
We're happy to have you. If you want to proceed, you can go on.
Thank you. So, hello, everyone. Thank you for being here. So, I'm talking to you from Dubai. I'm just 1 hour from Beirut time. I hope we will join this lecture today. Our lecture will be about the use of scleral lenses in the smoking phase for corneal cross-linking, but we are going also to talk a little bit about scleral lens fitting before going to the cross-linking. Okay. For financial disclosure, I am a local consultant for some scleral lens manufacturers, and I am the, as Ryan introduced me, I am the new ambassador of IACLE in North Africa. So let's talk about keratoconus. As you know, it's a most common primary corneal ectasia. It's a non-inflammatory by definition. Keratoconus is usually bilateral and asymmetric. So if you have a patient with keratoconus in one eye, it's just the other eye is just an infraclinic or a suspect eye with keratoconus. By definition, keratoconus is bilateral and asymmetric. This condition appears at puberty and progresses to the 4th decade of life, and then it stabilizes naturally after the 4th decade of life. Of course, we have a lot of forms or geometries of keratoconus, and we can classify these forms in 4 families. So we have the centered cone or the nipple cone. We have the oval cone that are usually decentrated in the inferior. We have the degenerative marginal pellucid, and we have the keratoglobus. For the management of keratoconus, it depends the stages. As you know, keratoconus is a disease that we can classify it into 4 stages. There are now new published classifications, but we mainly talk about 4 different stages. For the early stages, we can manage them with the spectacles. And of course, if the keratoconus is progressive, we have to perform cross-linking. More in the 2nd and the 3rd and the 4th stages, we have to use contact lenses to correct the irregular astigmatism. And we have a lot of types of contact lenses that we can use. It starts from the soft ones. We can use the soft torics in the early stages, and then we can use the softs with a higher central thickness. Of course, we can use corneal RGP lenses, scleral lenses, and hybrid lenses. Today, we will talk more about scleral lenses because it's the lens that we used in our study. I will just give some mentions about it. So the scleral lens is a large diameter lens. It is by definition a lens that settles only on the sclera, And the diameters, we have a lot of available diameters in the market. So in your country, or when you look at the labs that manufacture scleral lenses, you will find diameters varying between 15 to 17 millimeters. But you have also some labs that manufacture smaller than 15 millimeters. And we have also larger lenses, more than 17 millimeters. And this is study that it was a survey-based study that evaluated the diameter prescribed in scleral lenses. And as you can see, 65% of prescribing lenses were in average of 15 to 17. The anatomy of the scleral lens, usually here I don't talk about one design, I talk in general. Scleral lenses are manufactured in 3 zones. So you have the central zone when we have the where you have the optical zone, and just after you have the limbal zone. So that's the zone where the lens will be on the limbus, and you have the landing zone, or we call it the scleral zone, where the lens settle. And by definition, the lens don't touch the cornea nor the limbus, and settle only on the sclera. Okay. The fitting goals, so we have to clear all the cornea, and the limbal clearance must be a little less than the central clearance. The scleral alignment, we have all pressure of the lens that settle on the sclera, and this bearing of the contact lens should be not excessive. And we will see some pictures when we have a not correct scleral alignment. For the central clearance, what is the appropriate apical clearance? There are a lot of studies that talk about central clearance, and when you work with a lab of a manufacturer or scleral lens, he will give you some guidelines depending on the center thickness of the lens. But usually the central clearance is between 200 to 400 microns. And this appropriate clearance is very important to avoid corneal edema and to avoid touching on the cornea. This study from Professor Michaud and colleagues tried to explain the importance of the central clearance and the central lens thickness using different materials and using different clearances. So they went with different materials, and they evaluate corneal edema or corneal oxygenation through this. And as you can see, the thinner clearance give a better oxygenation, and of course the higher decay lens materials give a better oxygenation of the cornea. There are a minimal requirements according to this study. So we need in minimum 200 microns of central clearance, and preferably we use a material that have a decay superior to 150, and the central thickness of the lens must be not higher than 250 microns. The apical clearance is very important because the scleral lens will settle over time. So when you put the lens on the eye in the first hour, you have some clearance that you can measure using the slit lamp or the anterior OCT. But just after, this lens will not keep the same clearance. So this lens will settle on the sclera, on the conjunctiva, and then we will have a thinner apical clearance. And you have to take in account this settlement. The mean settlement in literature is about 100 microns. Of course, we need to know if we are fitting scleral lenses on the slit lamp, we need to know the central thickness of the lens, because we are going to compare the central clearance to the center thickness of the lens and not the cornea. This is very important because we are working with irregular corneas. You know, keratoconic corneas, they have a thinner pachymetry on the cone or on the center or the periphery of the cone, but after the cone we have a different pachymetry. So you don't use the cornea or the corneal pachymetry as a reference to calculate this apical clearance. And instead, you will use the contact lens thickness that is communicated by the manufacturer. And so you can fit your lenses properly. This is an example of a scleral lens at baseline. Like you can see the apical. I will just make some pointer. Here at baseline, we see that the central clearance is quite equal to the central thickness of the lens. So in the left, you have the lens. Between, you have the central clearance, and here you have the cornea. So here, when we compare this apical clearance to the central thickness lens, we see that it's mainly the same. But after 8 hours, we see that this lens has settled and the apical clearance reduced significantly. Of course, we don't need to touch the limbus where we have all the tissue or high sensitivity cells. So we have to have a clearance on the limbus, and the lens have to settle only on the sclera. Also, for the limbus, just one another information. We don't have to be. It's not good to have a higher clearance on the limbus, because we will have also some complications like limbus insufficiency. This is an example of a cornea with inadequate limbal clearance after removing the lens and using fluorescein, where we can see that the lens touch on the limbus and we have some staining there. Of course, the last zone that we talk about is the scleral zone. So it's the zone where the lens settle, and here we need that the lens don't we don't want to have a blanching here, so the lens will be or we need it to be appropriate at the landing zone. And here you can see in the OCT, anterior segment OCT, we can see that the settlement is very soft, and we are not here increasing the scleral vessel or the conjunctival vessels. This is a scleral lens fit scales that you can download. It's free. It's developed by the Michigan College of Optometry. So you can go ahead and download it. You can print it out and use it on your scleral lens fitting. For the management of keratoconus, if we see also in what we have also the surgical options. And mainly the surgical options are the penetrating keratoplasty. Of course, we have the penetrating keratoplasty, but we have also some anterior or some lamellar keratoplasty, depend the structure that we want to replace. And also we have intracorneal rings that are used to manage keratoconus, to manage vision. And lastly, corneal cross-linking to manage the progression of keratoconus when we have a documented proof that this keratoconus is progression, we can perform corneal cross-linking. So today we will talk about this procedure and how we introduce the scleral lenses to this procedure. The corneal cross-linking or the cross-linking of the human collagen is a physiological process. And the stiffening of connective tissue is well known in diabetes and aging. There are some other factors like smoking and diabetes, but mainly by definition during the cross-linking, there are some new chemicals bonds that are induced on the stroma, and this will induce a stiffening of the cornea. So the mechanism is that we use riboflavin, which is a vitamin B2. We use also oxygen supplementation and UV irradiation. So the riboflavin will penetrate to the stroma, and then the UV irradiation will activate this riboflavin, and new chemical bonds will structure on the stroma. The purpose of our study here is to determine the safety and efficacy of using a scleral lens filled with the transepithelial riboflavin as a reservoir during the soaking phase before corneal cross-linking. So we did a prospective study of 307 eyes with evolutive corneal ectasia who underwent accelerated transepithelial after 30 minutes of wearing appropriate scleral lens filled with the riboflavin. So what we do, so we take a scleral lens, we fill it with the transepithelial riboflavin, and we put it on the eye for the soaking phase for 30 minutes, and then we take it out and we perform cross-linking. I will show you some videos later. Of course, all patients had pentacam topography at initial visits, and there is a tool on the pentacam called Billen ABCD progression display, and we perform this measures every 6 months to manage the or to evaluate the progression. Also, we do anterior corneal OCT at 1 month after the cross-linking to look at the demarcation line depth. So the demarcation line is a possible sign of efficiency of cross-linking. So when we see it, we can say that our cross-linking is effective. For the scleral lenses here in our study, we used the AKS scleral lens from LCS France. We used the Acuity 200 as a material of the lenses and the diameter of 15 millimeters. Some patients had larger HEDV, so we used the 16.5 millimeters lenses. For the central clearance, we calculated empirically the central clearance with using anterior chamber depth and corneal pachymetry, and we added 400 microns. For the riboflavin, we used the transepithelial because in this study, we didn't take off the epithelium. It's an epi-on procedure. We call it epi-on. So this type of riboflavin is interesting because we don't need to remove the corneal epithelium, and we have a significant reduction of pain and danger of postoperative infections. And for the protocol, we used the standard protocol of 10 milliwatt for 9 minutes. Here you can see when we are performing the cross-linking. In some cases, but this is not the study. Today I gave a lecture on the World Keratoconus Congress about the sub 400 protocol, but I will not talk about it here in this presentation. But when we have thinner corneas, we use another protocol that is adapted to it. In this study, we used the CI device, which is a portable UV irradiation device to make the irradiation. And if you see here, we have some oxygen supplementation that we used in this study. So for the results, we have the riboflavin that diffused on all the cornea. You can see the color of the stroma that is yellow, and you can see here a little flare of in the anterior chamber. That is the sign that the riboflavin penetrates all the cornea. We had in our group, males and females, 52% were females, and the mean age was 21.6 years. And you can see the distribution of age. Here we have the minimal corneal pachymetry that was 445 microns. Of course, divided into several groups. We had some less than 400 and others more than 400. The presence of the line of the demarcation line, as I said before, is maybe a sign of efficiency of the corneal cross-linking. And in our study, we had a demarcation line at 300 microns of depth in 36% of cases in the two groups. Here I show you some examples of demarcation lines. That is the depth is almost 300 microns, but the important thing is that this demarcation line must be at least 80 microns above the endothelium, because we don't need to make damage on the corneal endothelium. So here in our study, the demarcation line depth was at 146 microns above the endothelium. There were no evolution was noticed during the follow-up of mainly 1 year, according to the ABCD Billen progression display. We don't have patients that had pain or epithelium issues because we are doing an epi-on procedure, and no significant AEs was noticed in this study. This is a case of a male 21 years old with a significant improvement at 1 month of the anterior and posterior curvature. So we know that after performing cross-linking, we have the phenomenon of corneal flattening. In this study, the study that I presented today in Dubai was about corneal flattening. But here I just show this case that had a significant corneal flattening at 1 month after treatment. This technique is not new. There are some colleagues that already used it, and we don't have a lot of published studies in literature that describe the efficiency of this technique and the safety. And we can see also that the material decay was not evaluated in some studies, but this is very important because we need a high decay to perform the soak-in phase with in a safe way. So in conclusion, I would say the scleral lenses are an effective tool to correct irregular astigmatism induced by keratoconus, and using the scleral lens to deliver riboflavin is a simple, effective, safe, economic, and delegable, and also time-saving way to soak continuously the cornea with transepithelial riboflavin before corneal cross-linking in ectatic corneas. This is our team. And this is a picture from my city, Algiers. And thank you very much for the invitation for the Vision Care Association. And thank you all the assistants for being here and listening to me. And I am happy to have some questions.
Thank you, Dr. Mohamed. If anyone has any question, please drop it in the chat box below. Meanwhile, I have a couple of questions sent privately. So the first question is this procedure FDA approved yet?
Good question. I was 10 days ago, I was in Boston presenting this technique at the American Society of Cataract and Refractive Surgery. And I had this question. It's not a simple response. It's not FDA approved, but we have to say something because we are taking off the lens to do the procedure. So the question is, if we put a lens on the cornea, we will induce corneal edema. That's okay. We know that, but when we take off the lens, the corneal edema will disappear in 90 seconds. So we are not working with a cornea that is in a situation of edema. So to simple response, there is no FDA approval, but I can say that this is very safe. There is a very safe method.
Another question from Layla. She's asking, is there any aftercare routine after this procedure?
Yes, so in the first month, there are some antibiotics drops that are prescribed by the surgeon, and we have to check out. We have to check up the corneal integrity just after 1 week or 2 weeks, and also we have to perform some exams like corneal anterior OCT and corneal topography, and also in some cases we perform what we call microscopy, specular microscopy.
Question from Enes. Can we use this method, cross-linking by the scleral lens with epi off, not on?
Yes, this is actually was my lecture today, because in the corneas that have less than 400 microns, we use the sub 400 protocol, which is a special protocol where we take off the epithelium, even with alcohol or with Schwind, so femto laser. And in this case, we use also the scleral lens in the soaking phase, and we take off the epithelium. So yes, we can do it, and we are actually doing it. It's just this study. I talk only about the epi-on cases. Maybe next time we will do the epi-off one.
Dr. Mohamed, another question. Does the cost increase or differ from the regular cross-linking surgery?
Very interesting question. Thank you, the one who asked. So the cost was mainly the driving for this idea, because we got this idea, of course, with our team in Ibn al-Haytham Center, because the riboflavin is actually expensive, and during COVID time we had some difficulties to have the riboflavin. So using the scleral lens, because you are using your trial lenses, and you can use the same lens after, of course, after cleaning, you can use it with other patients, and you are avoiding the use of high quantities of riboflavin. So you have just to put the riboflavin inside the lens, and you have the soaking of the cornea. So this is very cost-effective technique.
Another question from Layla. Is there usually a need to re-operate this procedure, or are the results usually successful with only one operation?
Okay. Usually, when we perform cross-linking, we are doing it once in life. But late, or we can say from literature, we have new studies that come out and say that the corneal stroma regenerate every 10 years. So the corneal collagen, which is mainly the constitution of this corneal stroma, regenerate every 10 years. And when we perform cross-linking, we are making chemical bonds into the stroma. So if this stroma regenerates and new collagen cells come out, we have to redo maybe a new cross-linking. This is one idea. The second idea is we can be not effective doing a cross-linking, and we have also we have to do the corneal topography follow-up each year to be sure to make sure that this patient is not progression. But in maybe 70% of cases, the first one is effective, and we don't have to do it again.
Any other questions? Okay, I think that's it. Dr. Mohamed, thank you again. We were so happy to have you.
It's my pleasure, Ryan. I don't know if Amir is hearing us. I hope he's doing better. And I was very happy to give this lecture, and please don't hesitate to write to me, even WhatsApp or email, if you have any questions. And I hope to see you soon in some meetings.
In Beirut.